So I will be talking on the Perthes disease. So the objective of my talk is, what is the Perthes disease? What are the common clinical features? What is the natural history of the Perthes disease? Commonly asked question is for the postgraduates, radiological features and the common classification. Why need to treat? The aim of the treatment of Perthes disease. Points, important words: preventive intervention, corrective intervention, and salvage intervention. Perthes is a very hot topic. 100 years over after it has been invented, still it is a lot of controversies there. I'm not going to involve into the controversy. I will clear the most of the established facts. So I'm not going in the controversy. The first and foremost is the Perthes disease. What is the Perthes disease? It's an idiopathic, self-limiting avascular necrosis of the capital femoral epiphysis. So if it is following the tuberculosis, infection, inflammation, if avian happens, it would not be considered as the Perthes disease. And commonly it is radiological diagnosis. Anything is sclerotic, avascular necrosis, it will be looking dense on the X-ray. So whenever we will get the child between 5 to 12 years where the avascular necrosis of capital femoral epiphysis happens without any etiology, it's idiopathic in nature, it is a Perthes disease. And second, the most important point for the definition, it is a self-limiting. So the avascular necrosis would be followed by the revascularization. So whenever in a left side, when we see about the avian changes, it will be called as the active Perthes disease. When there is no evidence of the avascular necrosis, it will be called as the healed Perthes disease. Where it is common, there are a lot of epidemiological factors, but it is somehow the unknown reason. It is very common in the southwest coastal plain. And whether we are fortunate or unfortunate, we need to have a lot of the frequency of the Perthes disease. Compared to the Western literature, the Indian literature do have the Perthes disease common in the rural area compared to the Liverpool, where it is common in the crowded area. And the age of onset in Indian scenario, the children are older than the Western population. Second, the age and sex ratio would be different in Indian, where we do find many girls are also involved compared to the Western literature. How to diagnose Perthes disease? Common symptoms between 5 to 12 years of age. Any child on this particular belt complain about pain and limp, you may think about the Perthes disease, very common in boy. The cardinal features, the main sign of the diagnosing Perthes disease is the restriction of the range of motion. And common being is the abduction and internal rotation. It may be mild, it may be moderate, or very rarely we will see about the severe restriction of range of motion. Most commonly, when we find the patient will have the abduction or internal rotation on one side from 5 to 12 years of age from this belt, we can think about the Perthes disease. We need to get it evaluated by the radiograph. The investigation of the choice for this particular patient pathology would be the plain X-ray. The EP radiograph would be the diagnostic. Frog lateral should be taken whenever the range of motion would be adequate. What is the natural history of the Perthes disease? As I said, from the definition itself, the avascular necrosis would be followed by the revascularization. So whenever it is a self-limiting disorder, the avascular necrosis happens, it will be followed by the fragmentation of epiphysis, revascularization, and complete healing. So it can be based on the natural history. The evolution of the disease can be classified into the 4 different stages. Stage 1 is avascular necrosis. Second stage would be the stage of fragmentation, where the new bone started from the periphery. It is the state of regeneration. And the 4th stage will be heal stage. And that classification is modified by Dr. Benjamin. It's called as modified Elizabethtown, which originally was the Waldenstrom classification. So I will show you the what is the different parts of the classification. So in stage 1, where is the avascular necrosis, and I said before there is a density of the femoral head would be more. So whenever the avascular necrosis happen and it will be in a single piece without any fragmentation, it will be stage of avascular necrosis. Further, it can be divided into two. 1A, where the height is maintained, where 1B, the height would be decreased compared to the opposite side. So this is a stage of the avascular necrosis. Whenever we'll see about the fissure running from the subchondral bone to the physis, vertical fissure, not about the horizontal fissure. Many of the postgraduate will get confused about horizontal fissure. That is a separate sign, but that would be considered as a stage of the fragmentation. In case of the early stage of fragmentation, single or two fissure would be present. That would be called as a early stage of the fragmentation. When the fragmentation number increases, that would be called as the stage of the advanced fragmentation. Then comes about the regeneration. The new bone forms from the lateral aspect. That is, the density of the bone would not be like the capital femoral epiphysis. The density is little less than the capital femoral epiphysis. It is stage 3A. When the newborn forms more than 1/3 of the capital femoral epiphysis, it will be called as stage of the advanced regeneration. And once it is completed, there is no evidence of the sclerosis. When there is femoral head density looks like exactly like opposite side, that will be called as advanced healing or the stage 4 healing. So this entire process will take around 2 to 4 years in every single patient. So if you divide that, it's that from the left hand side, the first stage of the avascular necrosis to the stage of fragmentation, then the early reconstitution, then it go for the healed. And that is the basic modified Elizabethtown classification. How does it help? It gives idea about the natural process of the natural history of the Perthes disease. And if we know about that, the most of the deformation or the femoral head changes happens in advanced stage of the fragmentation. So if you want to do any intervention, we need to do in early stage of disease before the head can go for the late fragmentation. So why need to treat this Perthes disease? Because the healing it's a self-limiting disorder. The femoral head gets complete revascularization, but in a process of revascularization, at the time of advanced fragmentation or early regeneration, femoral head may lose its sphericity, and that can be the coxa magna, that may be coxa brava, or that may be the irregular shape. And the irregular shape can be one of the reason precursor for the secondary osteoarthritis, and we need to prevent that, and that would be the goal of the Perthes disease. Before going for the goal of the Perthes disease, I will address few points, because most of the postgraduate would be asked by the traditional examiner, what do you mean by the different classification of the Perthes disease? In 1970, the widely popular classification in United Kingdom is the Cattrall classification. He divided into the 4, less than half, more up to half, the more than half, or the complete involvement. What is the importance or relevance of this classification? As and when, because the more head is involved, that would be associated with the poor prognosis. Less involved, it would be going with the good prognosis. Unfortunately, this classification can be only applied in the advanced stage of the fragmentation. So it would not be utilized for the decision making. It was used in decision making before, but historically it should not be used nowadays. Second popular classification is a lateral pillar classification. Thoughtfully thought about the classification when the height of the lateral pillar is maintained, that is A. When it is reduced to the 50%, it is type B, and when it is more than 50%, head is collapsed, that is a type C. What is the relevance of this? Again, that will be associated with the prognosis. It can predict about the prognosis. Heading C would be associated with the poor prognosis. But again, unfortunately, we cannot use this classification in early stage of disease. It can be applied only in advanced stage of fragmentation. Third and most important classification would be the Stulberg. Do not get confused with the modified Elizabeth classification, Cattrall and Haring classification, because Stulberg is used for the predicting the outcome of the disease. Evaluate the outcome of disease by the Stulberg 1. It is gone from 1 to 5. 1 is the best and 5 is the worst. What is a 1? After healing at skeletal maturity, if femoral head goes exactly like the opposite side, it will be Stulberg 1. If it is associated with mild enlargement of femoral head or shortening of neck, it would be Stolberg 2. When the AP and frog lateral, if the head looks like an umbrella or egg that is ovoid in nature, that would be as 3. So when AP and frog lateral diameter of the head would be different, that is a Stolberg 3. So when there is so 1, 2, and 3 are the congruent hip, where 1 and 2 are the spherical congruent, while 3 is aspherical congruent. The fourth one is that there is a flattening of the head, but the acetabulum will also remodel. So it is aspherical congruent is 4. Well, in a 5, that would be, you can see there is an irregularity of the femoral head, and acetabulum doesn't remodel. That is a Stolberg 5. So Stolberg 1 would be associated with very good outcome, and Stolberg 5 would be associated with the poor outcome. So what we learned that when there is irreversible deformation happens at the time of the fragmentation. So the aim of disease to prevent the deformation of femoral head, maintain the sphericity of the femoral head, and if child present late, we need to correct the alteration in the size and shape of the femoral head. If it is a heel Perthes, we need to treat about the sequelae of the Perthes disease to prevent the pain and prevent the arthritis. So somebody is going to ask, what is the treatment plan? Aim is to prevent the femoral head deformation, indirectly to prevent the degenerative secondary osteoarthritis. So depends on the stage of the presentation, we can divide into before the advanced stage of fragmentation. If child present early, it will be called as a preventive intervention. If child present after the stage of the advanced fragmentation, it would be remedial surgery, or if it is present beyond the stage 3B, it will be salvage surgery. Let us see one by one on the preventive aspect. So we are talking at the early stage of disease, stage of avascular necrosis and early fragmentation. There are the 5 important factors that will influence the prognosis of Perthes. That is the age of onset, stage of disease, the extent of epiphyseal involvement, the presence of epiphyseal extrusion, and range of motion. Earlier the onset would be associated with good outcome. Late age or the older age would be associated with poor outcome. The extent of involvement, as I said, more than half involvement, it will be associated with poor. Unfortunately, we don't see the patient with less than half involved epiphyses. The presence of epiphyseal extrusion, if it is present, it will be associated with, as the green said, more than 20% would be associated with the deformation of femoral head. Unfortunately, this is the only variable we do have control that has to be reversed. The range of motion, all the range of motion are restricted. We need to do restoration of the range of motion. We should never ever plan the surgery when range of motion is restricted. So how can we decide about decision making? Earlier the onset, younger the patient, we can treat conservatively, and the older patient, it requires the containment even before the extrusion, because natural history shows that those kids will go for the extrusion. Less than half doesn't require containment, more than half will require the containment. Earlier the stage of disease, it would be good because we have seen the ratio of getting the spherical head is 70 times higher than the late presentation. And range of motion restricted, never ever embark either femoral or the pelvic osteotomy. If the range of motion is restricted, it can be restored by keeping about traction. If you read about the Western textbook, they will be associated with the medial release and medial capsulotomy and adductor release. But it would be costly to give the traction in the Western literature. In Indian scenario, we can treat with the bilateral IK traction. And always reassess the range of motion after a few weeks of traction. If it is not restored, we can take the child under anesthesia and keep the broomsticks cast. Only consider containment after range of motion is restored. What are the containment surgery? It is 2 containment procedure. One is the femoral osteotomy and second is the pelvic osteotomy. There are advantages. It's easy to perform and it would be very easy. One postgraduate can do about the femoral containment. Pelvic osteotomy, that would not be associated with the limp or shortening. There is no verticalization of epiphyseal plate, but unfortunately, there is no article shows the pelvic containment can alter the natural history. Normally, it will require only 20 degree of varus and 20 degree of rotation. Whenever we'll do the varus, you need to associate it. We have to do the trochanteric epibasiodiasis in order to prevent the limp, permanent limp, because trochanter will go high. explain that how it is there. The red part is involved, so red part will go on the inside the acetabulum, and that is containment. How it has been achieved? Keeping the hip in abducted and internal rotated, and you can cut the osteotomy and make it straight, and that is the containment osteotomy. It can be done with the simple plate or blade plate. This is an example of the varus extension osteotomy. In cut short, when the age is more than 7 without extrusion, if it is happening, we can do about the containment surgery when the range of motion is restored. In younger age, if it is extrusion, we can do about the containment surgery between 5 to 7. The few example, 5-year-old boy without any extrusion treated with conservative treatment, and at maturity it's a good outcome. Another child, 6-year, is presented with the early stage, but there is extrusion, 35% of extrusion, so it was treated with the varus derotation osteotomy, and the 5 years later we can see the spherical congruent hip. The 7.5-year-old child, as it's presents at the early stage of disease with extrusion, we are very aggressive on treating and that, and the skeletal maturity we can see the spherical congruent hip. Always do the trochanteric epiphysiodesis, because we have seen that it will work up to the 10 years of age, and this is the working in the trochanteric epiphysiodesis. I'm not going in detail about controversy about the Perthes disease, but there is no level 1 study for that. What should we do if child present late in the remedial or the late stage of fragmentation? What are the problem? There is extrusion and the hinge abduction. So it may require the containment, but chances of getting about the spherical head would be very less. So we need to think whether the child has got hinge abduction or not. So what do you mean by hinge abduction? If there is a, when we abduct the hip, the center of the femur head and center of the movement happen at the same place. When we have the hinge abduction, the center of the rotation of the hip joint will move on the side and the lateral margin of the acetabulum. So if you see the joint space in abduction, it will be uniform in case of the normal abduction. But if in case of the hinge abduction, it's crescentric widening, it is medial joint space would be more, and that is the hinge abduction. It is easily detected on the plain X-ray, but whenever we are in doubt, it can be associated with the medial arthrogram, medial pooling of dye. And the clinically we can detect by reducing the range of motion. We can say that severe restriction of the range of motion in the later stage of disease, and whenever in doubt, we can see about the medial pooling of dye. What should we treat the hinge abduction? There are multiple treatment options, but once it is post-collapse, I will say that we are not going to get the spherical congruent hip like Stulberg 1 in most of the case. If it is not coxa magna, if it is not associated with hinge abduction, it can be treated with the varus derotation osteotomy. If it is there, it can be done with the valgus osteotomy or Chiari osteotomy or the Stelf osteotomy. But beware that Stulberg 1 and 2 are not very common. Few points on the salvage surgery, because it is fancy and it's new. Sometimes it would be asked for the recent advances in the pediatric orthopedic or Perthes disease. What should we do if it is associated with coxa brevis, magna, or irregularis? How does it work? It will increase the stress across the hip, in fact of the intra-articular or extra-articular impingement, and it can lead to the more stress across the hip. It can lead to the secondary osteoarthritis due to the joint irregularity. So what is the treatment? If it is only isolated coxa brevis, means short neck, it can be treated with the trochanteric advancement, and we can do the distalization and lateralization of trochanter and fixing with these 2 screws. That was a traditional historical treatment. Recent advances we can do about relative neck lengthening. Take out about trochanter piece, take the central bone and take the distal and lateral advancement of trochanter and fix with 2 screws. Or if this is the example of the relative neck lengthening, or if it is associated with the shortening, we can do about the third osteotomy below about the inferior aspect of neck and fix with the screw. That is a Moscas osteotomy. This is an example of the Moscas osteotomy. What should we do for that? Again, I will urge that this surgery should be reserved whenever we'll get the spherical or the ovoid shape. Should not do for the frankly irregular hip. What should we do for coxa magna and irregularis? It can be dealt with the osteochondroplasty if it is impingement, or Grant's head reduction osteotomy. Like this case where there is an osteochondroplasty can be planned because of the femoroacetabular impingement, and we can do with the spherical template at the safe surgical dislocation and do about the distalization of trochanter relative neck lengthening. And Gans osteotomy, we can do about the central part defect, take out about the head reduction osteotomy and fix it with the screws and plates. But we don't know about the future of such surgery. In the long-term result of this surgery is unknown. The conversion of total hip replacement is more than 25%. The salvage option of for the relief of pain may be femoral head reshaping, hip arthrodesis, or total joint replacement, depends on the patient need. It concludes, Perthes is a self-limiting disorder. It's an idiopathic avascular necrosis, common in Southwest. Abduction and interrotation is key for the diagnosis. Plain radiograph is the diagnostic. We can see about sclerosis and collapse. Prevention of the femoral head deformation is the prime goal. And containment, if you plan, you need to do in early stage of disease. Thank you.